The standard in most European countries are a triple induction regimen with a proteasome inhibitor and an IMiD. Most of the times Velcade or bortezomib, which is the same, and then the combination with thalidomide or lenalidomide and then dexamethasone. And that's what's in most European countries is in our guidelines, because that's approved and reimbursed. And that's what we are experienced in. Then the autologous stem cell transplantation, and I tried to search for all the studies who did a randomization between the standard regimen and that without. So you have a big trial, the IFN 2009 trial, who was comparing the RVD with an autologous stem cell transplantation and without. And you can see that the progression-free survival is a little bit better for the patients treated with an autologous stem cell transplantation. However, the overall survival is equal now. Maybe the data are not mature, that's why they also looked at MRD, minimal residual disease, and also the patients treated with only VRD reached MRD. However, the percentage was a little bit higher in the patients treated with autologous stem cell transplantation. So in the current standard of care, I think we would still say that an autologous stem cell transplantation is of benefit. However, you have new generations of proteasome inhibitors like carfilzomib, and also studies are performed with that, and the most promising study, I guess, at this moment, because it's randomized, is the Forte trial, which randomizes KRD, autologous stem cell transplantations, and then consolidation with KRD versus only KRD. And the first results were presented at ASH last year by Francesca Guy, and she told us that before the maintenance phase, the MRD rate and also the response rate was equal between both arms, and that's maybe promising. Of course, we have to wait for the further results, but that's promising. And this is a combination with a new agent, proteasome inhibitor, but you also have studies with daratumumab or other monoclonal antibodies added to our triples with the proteasome inhibitor, IMiD, and dexamethasone. And these are also promising, although there are no real studies now who are randomizing between these regimens with or without a transplant. But like my colleague Graham Jackson, who was later on the topic, already mentioned, when we look at the MEA trial, these are transplant non-eligible patients, so somewhat older. But when you look at the combination with daratumumab, lenalidomide, dexamethasone for these patient group, and they continue, then you see excellent response rates. And we would need a study to compare these with and without a transplant in these young and fit patients. Maybe we can rid of the transplantation, maybe not, but we should do research for that.